about rasavaha srotas. Now, rasavaha srotas itself is again a bit of controversial issue. The description of the rasavaha srotas in Sushruta is a rasavahe dve. There are two components of the rasavaha srotas. Tayor moolam hridayam rasavahinyasya dhammanyah tatra viddhasya shoshah pranaha viddhavaccha mranam talingani cha. Now, the clinical rasavaha srotas has its source in heart as such, hridaya, and dhammanis. Now, the word dhammani doesn't mean only the arteries. This is what we have already discussed earlier. The vessels as such, and those vessels which contain carry as such. And if there is an injury to that, it will result in shosha, emaciation, and all the clinical symptoms of pranavidya lakshana or even death can occur. Now, a further more description about these srotas would be seen in the Samhitas. In Ashtanga, there is a description of these functions of these as in the context of pranavata. Tatra pranaha murdhyamastitah kantha urastarah buddhi indriya mano hridaya manaha dhammani dharana. That word dhammani dharana, maintenance of the circulation, is one of the important functions of the pranavaha srotas. In the same samhita, again, the description of the rasadhatu is mentioned as a vyanena rasadhaturihi vikshipyochita karmana yugapat saroto ajasram dehe vikshipyate sada. The vyanavata, it helps in maintenance of the circulation, vikshepo uchita karmana. A proper circulation is maintained by the vyanavata, and rasa is defined as aharaha gacchati rasaha. The movement, it moves continuously, and hence it is called as rasa, and because it is circulated throughout the body. So, to identify rasa now in the context, in the present physiological context, many people say that it's a kail and so on. I don't say that. It's the hemodynamic component of the blood. See, you cannot separate the nourishing function of the blood and the hemodynamic component of the blood from the current point of view. We consider them together. But when we say cardiovascular system and the functions of that cardiovascular system, there are mainly two functions. One is about circulation, that maintenance of the circulation, fluid movement, and the other is about the maintenance of the nourishment, oxygenation and the nourishment. Now, the hemodynamic component, that maintenance of the pressure and the fluid movement and regulation of that, is one of the functions of the heart, the pumping action of the heart. Whereas the nourishment and oxygenation, it's a very complex function. The nourishment is carried from the absorption of the food, from the absorption of the nourishment from the gastrointestinal tract and reaching to the tissues through different mechanisms. Oxygenation is carried from the lungs to the peripheral tissue. Now, this kind of functions are now considered as integrated, and you do not make the difference. From Ayurvedic point of view, the function of the pumping activity are a function of the hemodynamism, and of course, to a certain extent, the function of providing the nourishment is considered as a function of rasa. So, in that, the red component, that's the hemoglobin, doesn't have much a role in that game as such. Whereas when the same becomes red, rasa ranjana, that becomes the rakta, and the rakta is maybe the hemoglobin and that red cell component which we may identify. I think that kind of a differentiation is not necessary, but primarily when it comes to the question of rasa, we will be always considering the hemodynamic components as such. Now, in Sushruta, there is a further more description about these structures, and these structures are mentioned in the form of the sira. The circulation of this would be in the form of the sira, and the functions of the sira are very clearly described in terms of a movement from the heart to the periphery, as well as the movement of the blood from the periphery to the center or the heart as such, and this a continuous circulation, though the base is considered as a nabhi. Sirashalani bhavanti yabhi idam shariram aramema jalaharanibhi केदारैव कुल्याभिः उपस्निह्यते अनुगृह्यते च आकुञ्चन प्रसराणादि विशेषैः धूमपत्र सेवनेनां तासां प्रधानाः तासां नाभिर्मूलं ततश्च प्रसरन्ति ऊर्ध्वमधस्थिर्यक्ता. The siras mentioned by Sushruta are those vessels which carry the nourishment or the fluid from the source, main source, to the area which requires. So, and the simile given by Sushruta is aramaya jalaharnibhi, like a garden being irrigated through the channels from a water source. And then there is another function like Kedarivachakulyavihi, like a water pond which is having this accumulation of the water from different sources of water, and the water is accumulated. So there is a sort of circulation. Water comes to the pond from different sources, and the water from the pond moves towards the periphery. Now this is exactly how the functions of arteries and veins are described. The function of the artery is to carry the blood from the heart to the peripheral areas where it is required. That's the arama eva jalaharanibhi, like the garden being nourished from the water sources, and the blood from the periphery reaches to the heart to be pooled together. That's exactly Kedara Etakulyabi, and these functions are maintained by the contractions and relaxations, Akunchana Prasarana Vivisheshihi, and these vessels, they have very finer branches to the level of capillaries. That's Dhumapatra Sevaninam Tasam Pratana. So the description of cardiovascular system as a closed system and circulation of the fluid is very well described, though the details of the hydrodynamics, the dynamics and pressure measurements, they are not mentioned in the Samhitas. So 5000 years back, Ayurveda has described these functions very clearly, and it has differentiated the two aspects, two functions of the circulating fluid. That's one is to maintain that circulatory pressure and the fluid movement. The other part is about the nourishment and oxygenation, which is now which is categorized as rasa and rakta, whereas in the current physiology you do not make out that difference. And this invention of the circulatory system, and that circulation in the Western system, is a very late concept. The concept of the circulating blood in Western medicine historically is very odd, and the credit of this identification or the identification of a closed circulatory system goes to Harvey in the period of around 1578 to 1627. In his time, William Harvey is considered to be the first person or scientist who established the circulatory system. Earlier, the concepts of the circulation in the Western medicine were something very awkward, like the oldest was there is one vessel will be carrying the air separately, and one system will be carrying the blood. It is considered to be open-ended, and the blood would be connected to the divine, the exterior. That's how the concepts were, and the concepts were modified, like air and blood in the arteries, and then the blood in the veins, and arteries and veins were made out. That even different theories were there, Callan's theory and Colombo's theory. All of them were a situation where they didn't know that the same blood which comes to the comes through the arteries will be again going back to the vein, and there is a continuous circulation. This kind of a notion was not there in the Western system, whereas this was well established in Ayurvedic point of view, though the credit of this invention of a closed circulatory system was given to Harvey, but primarily this should have been gone to Ayurvedic scholars. Anyway, as far as the circulatory system is concerned, one of the important parameters of the circulatory factors or guidelines would be the circulatory pressure. Now, measurement of the circulatory pressure itself is a very complex issue. Till 1896, the circulatory pressure in a live animal or live human being was not possible, and or rather without really cutting the vessels. All that methods of identifying the pressure was by cutting the vessel. connecting to a this manometer or some instrument, and measuring the pressure was there. But a cuff-based mercury sphygmomanometer was invented by the Italian physician in 1896, and all that clinical ideas of circulatory pressure or hypertension were maybe made possible in 1896 and onwards. But the real standardized method of assessing the blood pressure without cutting the vessel or in a intact human body was established by a Russian physician called Nikolai Korkov, and he defined that systolic and diastolic blood pressure measurements without really cutting, and what we call is now still as called as Korsakoff sounds. The current method of recording the blood pressure, that we try a cup and then hear the sounds of the systolic and diastolic pressures, and these sounds are called as Korsakoff sounds based upon the Nikolai Korsakoff who identified this. So all that what we know about hypertension as a disease. So now the whole our topic now would be about hypertension as we see in the clinical practice, and I would consider this as an abnormality of the rasavaha srotas and the functions of the rasa, and hence one of the diseases related to the rasavaha srotas will be hypertension from the current point of view. And all that knowledge which we have now about the hypertension and its management is just around 140 or 150 years old. That's it started. The whole idea of assessing a blood pressure clinically was possible in 1905, and it's around 120 or 119 years till that period, that whatever we know now is about the circulatory pressure. And the real identification of defining essential hypertension and its pathological consequences, the malignant hypertension which can result in a more complication, it was established only in between 1910 and 1914, somewhere around maybe 5 to 10 years after the Korsakoff sounds were identified, that this possibility of an organ damage and considering hypertension as a disease was established only in that period. The real assessment of the hypertension and its assessment of the risk was standardized only in 1948, and historically this was 1948 is just not even 70 years, maybe around that period, 70 plus years, and this was again considered as a standard parameter after President Roosevelt's death. President Roosevelt, who was American president, and he had a high blood pressure. Earlier, this high blood pressure was not considered as a disease entity, or there was no method of standardizing this. And the standardization was done after Roosevelt's death because he had some hypertension complications. And the later period, 1948, when President Truman was the president in USA, a National Heart Act was established, and that National Heart Act had established a method of assessing the risk of the circulatory pressure, and this is considered as a Framingham heart study, and Framingham risk score is one of the basic issue, and the risk of cardiac pathology is calculated by Framingham risk factor by assessing age, gender, smoker, cholesterol level, HDLC, systolic blood pressure, and hypertension medicines. And this is started in this graph, and based upon that the risk factors were calculated, and this is still now the Framingham risk calculator is still in use when it comes to the question of predicting the risk of complications of the circulatory pressure. Of course, these were slightly modified from the period of Framingham, slightly. The current Framingham risk calculator, it involves these 7 factors to be added, and risk of cardiac pathology is predicted now. That's how it is done. Now, as far as the issue of what is the normal circulatory pressure, another of the highly controversial issue. The normal circulatory pressure, it was defined at different time periods. In 1970, first the cooperative society, VA cooperative society, had given the guideline like there is something like a normal circulatory pressure and there is some abnormal pressure. And the initial 1980s, the standard normal blood pressure was considered as 160 by 90. So anything above this was considered as hypertension, and below, of course, 160 by 90 was considered as a normal pressure. But later on, there was a continuous review, and the reviews were done at different time intervals. In 1997, the normal circulatory pressure was brought down to 140 by 90, and then in 2017 it was brought down to 130 by 80. So all that what we know about the circulatory pressure and hypertension and its relation is a statistical analysis, and these are revised regularly. And latest after 2018, latest is if the circulatory pressure is more than 110 by 60, even then that has to be considered as a hypertension. Now most of these modifications were guided by pharmacological companies, interests of the pharmacological companies, which will increase the market size of the so-called antihypertensive drugs. Now anyway, currently the guideline which is given, the broad guideline by American Heart Association and American Stroke Association, which is now considered throughout the globe as a standard, is considered systolic blood pressure of less than 120 and diastolic pressure of less than 80 is now considered as normal. And if it is in between 120 to 129 and the diastolic pressure remains 80, then it's considered as just elevated. A pressure between 130 to 139 is considered as a high blood pressure stage 1. If it is more than 140, it is considered as stage 2. And if the patient has more than 180, then it's considered as a hypertensive crisis. But interestingly, these standards are for Western countries where the environment is cold and the food intake patterns are of different pattern, and every modification by standard reduction of this blood pressure by around 10 millimeters of mercury at every revision has added to millions of dollars to the pharmacological companies. Now, if you look at the patients who come to you now, almost majority of the patients majority of the people, normal persons, would have a blood pressure between 140 to 90. And those persons who have a blood pressure of less than 120 by 80 in our condition, they would have most of the time some depressive symptoms. They may not be normal. So that's the real issue. So there is a need for making a standard parameter for our Indian population and Indian living conditions. And even with this normal pressure also, there is a lot of differences between different groups as such, different medical groups. JNC group, the general blood pressure now is attributed to 140 by 90, or above 60 years 150 by 90 as a normal, and the goal is supposed to be 140 by 90 when you treat the diseases. In the ESH standard, again 140 by 90 is considered as a normal. So 90 millimeters of mercury as systolic is still again considered as a normal range by many of the organization, but still there is a lot of controversy and there is a continuous revision. In 2020, the normal circulatory pressure was reduced to 120 by 60. Now again it's raised by 140 by 80, the latest. Another of the major issue with the measuring the blood pressures and establishing like whether a person is the hypertensive or not. There are many critical issues which make the complications or which make the assessment of the circulatory pressure as erroneous and unnecessarily considering many people as a hypertensive. There are many factors. One of the factors is the circulatory pressure is never same throughout the day. It varies according to the activity, physical activity, as well as the diurnal changes, time changes. Like in general, in any person, it will be varying according to the time. the time interval, like usually at night the blood pressure would be lower, comparatively lower, and at the active phase the blood pressure would be slightly higher. There will be a fluctuation. Moreover, when you go to a physician or a medical unit and the blood pressure is measured, the person should have some anxiety, and that anxiety itself would be increasing the circulatory pressure high, and hence many times the recorded blood pressure in a medical unit is considered as always higher, and that is called as a white coat blood pressure. White coat blood pressure because the blood pressure would be, you will be wearing a apron itself would be a cause for the hypertension also. So measurement of the blood pressure there itself is erroneous. Moreover, the standard method of assessing the blood pressure would be, again, like it's not that a single recording is to be considered as a standard. The ideal is the patient has to be in absolute rest for at least 5 minutes, and the blood pressure has to be recorded in the lying down posture. At least 3 recordings have to be done in a gap of 5 minutes each, and then the average of the 3 is to be considered as a blood pressure of the person. But in a practical clinical situation where you have a continuous flow of patients, this kind of a measurement is practically not possible, and most of the times we make use of, or we consider many people as hypertensive unnecessarily, and the medicines are overprescribed. So overprescription of medicines in a patient considered to be hypertensive is a very common thing and one of the practical problems. And recording the blood pressure in the erect posture and immediately after the patient visits you, these are not the standard practices, but still we do have to do that compulsorily in the practical clinical situation, and we need to have some standard parameter to save the patient's asset. Moreover, the pressure, when we measure the pressure, we measure the pressure from the peripheral artery. Somewhere when you tie the cuff over the arm, its brachial artery pressure is measured, but the pressure is not the same throughout the body. The pressure in the aorta is always higher, and when it moves towards the periphery at the arteries, depending upon the dimensions of the artery and its distance from the heart, the pressure would be gradually diminishing. So when we record the pressure at the brachial artery, the pressure may not be the same as that of the pressure in the heart. So ultimately the blood pressure will be really acting upon the heart muscles. It's a function of the heart muscle, and the load is on the heart as such, and that is not directly measured when you measure the blood pressure at the periphery. And the pressure in the capillary is always low, and towards the venous side it will be going towards the negative side as such, because the blood has to flow back into the venous side, and hence the whatever we consider as a measure blood pressure is simply a wrong, rather something like catching a black cat in a dark room. So it's not really the real situation, but all that is a sort of guess and based upon the certain standard parameters which are established as such. Anyway, that's about what is hypertension. But important is how the pressure is maintained, the regulation of the blood pressure. The functions of the rasavaha, srotas or pranavata, according to the Sushruta, would be by regulation, these mechanisms of the regulation. These mechanisms of the regulation are in gross in many stages. One of the mechanism is a central nervous mechanism. Central nervous mechanism is through the chemoreceptors in the middle of longata, the oxygen concentration as well as the other chemicals, they are received in the chemoreceptors, and that would be stimulating the cardiac motor center, and through that cardiac center and through the nerves, the sympathetic nerves and the parasympathetic nerves, the heart functions are regulated. When the sympathetic nerves are stimulated, the excitability of the heart would be increased, heart would be pumping more, there will be a positive ionospheric functions, ionotropic function. The heart's rate also would be increased, and the strength of the contraction of the heart muscle also will increase. When the parasympathetic functions are stimulated, parasympathetic nerves are stimulated, there will be a lesser, it will be directly acting on the SA node, synovial node, and the synovial node would be at a lower pace, and the rate of contraction would be reduced, and the circulatory pressure also will be reduced. Sympathetic stimulation, it directly acts on the skeleton, these cardiac muscles throughout, and hence all the muscles will become more excitable. So, and that's one of the mechanism by which the circulatory pressure is maintained in the body. The other mechanism is the renin-angiotensin mechanism. When it depends upon the regulation of the circulatory pressure in the kidneys. If the blood pressure or the blood flow to the kidneys is reduced, then the juxtaglomeralar apparatus in the kidneys, that will secreting the renin, and that renin hormone will be converted into angiotensinogen in the lungs, and angiotensinogen would be directly acting upon the adrenal cortex, and that will increase the sympathetic outflow. At the same time, angiotensin also would be directly acting on the peripheral blood vessels, and blood vessels will be constricted, and that's how the circulatory pressure is increased, and that circulatory pressure increase will increase the blood flow to the kidney, and hence there will be a homeostasis, maintenance of the normal circulation. That's one of the mechanisms. So central nervous mechanism, renin-angiotensin mechanism regulated through the kidney. Then the third mechanism is the ADH mechanism through the asthma receptors. The asthma receptors, they will be sensitive to the total water content in the body and the electrolytes content in the body, and that detects the correct osmotic pressure, and through that to maintain the osmotic pressure, the ADH is secreted, and when the ADH is secreted, antidiuretic hormone is secreted, it acts upon the kidneys to reduce or increase the reabsorption of water at the distal convoluted tubule. Antidiuretic hormone, it increases the reabsorption of water and sodium, and this water and sodium would be increasing the volume of circulation, and as the volume of the circulation is increased, the blood pressure again is increased. So increased blood volume as well as increased blood pressure occurs, and this way the circulation, total circulation is established. So that's another of the mechanism which maintains that. So primarily, though there are many other mechanisms, the most important mechanism of maintaining circulation pressure are the central nervous system mechanism, renin-angiotensin mechanism, and ADH mechanism, which are very important. In addition to that, there would be many other factors which also would be regulating the blood pressure. Your physical activity also would affect the blood pressure. Temperature around acts upon the blood pressure. Many hormones like thyroid hormones, sexual hormones, they also would be acting upon the blood pressure either indirectly or directly. But from the clinical point of view, we consider the major three factors as the factors which regulate the blood pressure. Now, the importance of the assessment of the blood pressure and hypertension as such is another of the factor. It's again purely based upon the statistical analysis, because the hypertension is considered to be a silent killer. By itself, it doesn't produce any symptoms, but it can produce damage to the body, and the damage produced to the body or systemic complications produced due to the hypertension are again based upon the statistical analysis. One of the major risks which are considered to be a complication of the hypertension is the cardiac complications. A large study population based study was done, and based upon that, the observation is the life expectancy in a patient who has a higher blood pressure above normal is lower than the persons who have a normal blood pressure. Every normal blood pressure also has a risk. A patient with a normal blood pressure also would have a risk of either the cardiac disorders or myocardial infarction or stroke, or maybe even the other complications. So these, but the total risk is now this long line, the third line. It represents the life expectancy, but risks of these complications are still there. Whereas a person who has a hypertension would have a shorter life expectancy, the risks are slightly higher. See, risk of developing a cardiovascular risk or stroke in a person with a normal pressure is, if it is statistically given as 2.8, The same is 3.9 in a patient with hypertension. So this kind of a set, and this is true in females. In males also, it is a similar issue. According to the data of these major source, there a huge population study. This gives you that idea, like why the hypertension is important. That's one. Then the other is hypertension can result in damage to the other vital organs, and this is one of the major complications. It's not only the cardiac pathology, it can produce other complications also, and the complications could be either, it could be like cardiovascular complications, which are very high in case of hypertension, and the hypertension can produce also retinopathy, which is comparatively lesser incidence than that of the cardiovascular. Creatinine levels resulting in renal pathology, again one of the complications, and regional motion abnormality in the heart, that's the myocardial movement, is also another of the complications which can occur, or proteinuria or neurodeficiency, cerebrovascular accidents. These are the complications which can occur due to hypertension, and the statistical representation. The majority of the people would have cardiovascular complications like coronary artery disease or left ventricular hypertrophy. So left ventricular hypertrophy is the earliest change which produces due to a increased pressure of circulation. And the cardiovascular mortality also is higher in a person who has a hypertension. If the normal circulatory pressure, the cardiovascular complication, if it is considered to be 1 in the patient who have a blood pressure of 120 to 80, if the blood patient is in a stage 2 hypertension where the diastolic pressure will be more than 110, it's considered to be 2.06. So that's how the risk of cardiovascular mortality is increased both in male and female. And this is from the India. This data is from the India, the Indian people population study, but not as high as population. The total number of people studied is 87,459 males and 59,368 females. Comparatively large study, but not in that world international level. But one of the major studies from India which has given you the statistical analysis of hypertension and cardiovascular mortality. So it's almost double the risks of cardiovascular mortality. From 1 to 2.05, double is the risk. And the coronary risk factors it will be added further. If a patient is hypertensive, the risks are more, but the risks are further enhanced if a person has a high density lipid level, or if the cholesterol level is increased, if the person is smoking, if the person is diabetic, and if the patient already has a left ventricular hypertrophy, then the risk will be increased. Now, this data gives you the idea. If the cholesterol level is 180, the risk is comparatively lower. When the cholesterol level becomes 240, at the same time, so if the cholesterol level is 240, but the high density lipid is within 50, and there is no smoking, non-diabetic, the risk is not very highly increased. Whereas if the person has a high density lipid being lower and cholesterol level at 240, then the risk increases. If the patient is smoking, the risk further increases of cardiac coronary risk factors. So when it comes to the question of coronary pathology, the important is it's not only the hypertension which is responsible for that. You have the other multiple factors which are responsible for the cardiac pathology, but hypertension is one of the major factors, and when you have multiple risk factors, the incidence of coronary pathology would be much higher as such. Now, as far as the abnormalities of the lipids and the hypertension as a cause, now abnormal lipids are considered as a cause of hypertension. Now, this again is a very unstable theory, a theory which is changing its pattern, and again most of these theories are based upon the interest of the pharmacological companies than really the real statistical analysis. In 1910, the atherosclerotic plaques which contain cholesterol were identified, and cholesterol was considered to be responsible for that. And high cholesterol causes atherosclerosis in rabbits. It was invented in 1930. and heart attacks were identified to be related to the cholesterol level in 1919. So all that whatever that lipidemia presenting or hyperlipid conditions resulting in cardiac pathologies in human beings is a knowledge which has come up after only 1919. And then gradually the risk factors concepts were advanced in 1958. So practically the clinical methods where the people are recommended to follow the diet factors and risk factors being reduced as a suggestion was in 1953. Then there is a rapid change in the concepts of these lipid levels. In 66, low density lipid was identified as a risk factor for disease. So it was shifted from cholesterol to low density lipid, and hence post 1955 is considered as era of LDL, and the prior to that it was considered as cholesterol. So the target of the physicians to regulate these lipid level were changed from cholesterol to LDL, and this again I would still say that it's all the interest of the pharmacological companies and really the interest of the human being. Entry of statins in the market was in 1970s earlier, and it was considered that statins increase the LDL receptors in the body, and the statin was introduced for the human use in 87. Now in the present day situation, almost every a person who visits a physician, cardiologist as such, irrespective of the condition, statin is as prescribed, and it's one of the major market regulated drug asset, statin, and that's another of the issue. Anyway, that's about the current situation about the complications of the hypertension and the perception. Now, stress as a cause of the hypertension is the real another issue. It's now studied well, and the behavioral stress, cognitive stress, emotional stress, as well as physiological stress is considered to be the cause for the hypertension, and that results in acute stress response, and this is considered to be the one of the major issues. And idea of reduction of the stress and relaxation methods as a remedy for hypertension is one of the latest concepts in such. And one more of the latest concept about the hypertension is about the oxidative stress. Oxidative stress is a metabolic issue. When oxidants are the intermediary metabolic products, AMA, that's ideally the AMA. Oxidants are something like free molecules, free radicals, which are released during the process of oxidation of the nourishment in the body. See, every oxidation process, the energy is produced by oxidation, and if there is improper oxidation, something like a smoke coming when you burn a object. See, if an object is burnt well properly, there will be no smoke or little smoke. But if the object is wet or not in a proper condition for burning, that will release smoke. So oxidants are of that sort. That's exactly what the description of AMA in Samhitas are mentioned. So AMA is now coming to the fore, and this also is another of the latest theory about. So presence of these oxidants also is one of the causes for hypertension, which affects the brain, kidney, heart, and then the whole mechanism, the adaptation of the vessels are affected, and that's how the hypertension is produced. That's another of the theory, latest of the theory. Now, one more issue is hypertension now is classified as primary hypertension and secondary hypertension. Primary hypertension also is named as essential hypertension, where you do not identify any other pathology except those factors like lipid levels or the physical activity, stress, etc. But when you identify some other disease conditions which can result in hypertension, like abnormal aldosterone level or abnormal kidney functions or tumors of the kidney fulcrum or tumors of the adrenal cortex, or if there is abnormal secretion of the hormones, these are considered secondary. But practically, more than 70, average around 70% of the patients whom you see in the clinical practice of hypertension, they are primary, or there may not be any other hormonal pathology. Secondary hypertension patients with the other basic pathologies like epiphromatocytoma or renal failure like conditions, their approach to them would be totally different, and those have to be considered as such. Now, secondary hypertension also is related to the drugs. Now, I have just copied from one of the major articles related to secondary hypertension, and the causes which are mentioned, drugs which are possible cause for the hypertension in that article is from the National Committee of Prevention, Detection, Evaluation of Blood Pressure from a very reputed institution, National Heart, Lung and Blood Institute from the USA. The point is the drugs which are mentioned are oral contraceptives, amphetamines, non-steroidal drugs, psychiatric drugs, steroids as such, and sympathomimetic drugs. Along with that, herbal drugs like ephedra, ginseng, etc. This is from USA, not from India. Is considered as a cause for the factors which add to the hypertension. Now, many of the contemporary physicians from India, they have picked up this sentence like herbal, and many of these physicians, they said many of the diuretic drugs would increase blood pressure, and a propaganda of that sort also is now gaining some popularity, but that's not really true as such. The malignant hypertension can occur when a hypertension increases. It can produce many complications. The complications which can occur could be anywhere in the body, any system could be affected, and the most common factors which can get affected, tissues or organs which could be affected are kidneys, where there could be a necrosis of the arterioles in the kidney, and the arteritis can occur. In the heart, ventricular hypertrophy, diastolic dysfunction can occur. Retinopathy is the other, and retinopathy, it can produce the damages in the retina, X-rays could occur. Even there could be a very late complications of a wool spots where the retina will be fibrosed. Brain neurological symptoms or edema in the brain, or microangiopathy where the thrombocytopenia could occur, hemolytic anemia also could occur, and the whole mechanism, the physiological changes would occur as there could be ischemia in the kidneys, and renin-angiotensin mechanism could be activated more rapidly. This results in a vicious function. See, once the blood pressure is increased beyond a certain limit, there will be further damage, and all these damages would be further enhancing the circulatory pressure, and that would be a vicious cycle, and that's called as a malignant hypertension. As far as the causes of hypertension are concerned, now I have copied it from one of the important slides from webmed.com, not a very standard one, but this is a copy of presentation, not my presentation. The 15 things which increase the blood pressure. This is now, and very, very important, there is your doctor. A person going to a physician, and in the presence of that environment of the hospital, maybe the fees they have to pay for visiting a doctor also, any of those factors is considered to be one of the major causes of the hypertension, and it is absolutely true. The other factors which also can increase blood pressure are added sugar in the diet, a feeling of loneliness, sleep apnea, potassium being deficient, pain having, then herbal supplements. Again, in that condition, herbal supplements are considered as one of the causes. Again, that issue. Thyroid pathologies, retained urine, drugs like NSAIDs, nasal decongestants, dehydration, hormonal birth control, quarreling, antidepressants, these are the issue. Of course, this is not a very standard issue, but interesting is your doctor being a cause for hypertension is one of the important issues. Now, as far as the management of hypertension is concerned, the guideline of 2017, it says something and the practice is something different. So, to describe this, it takes more time. So, we will take up this in the next session, like the guidelines and the management of hypertension from the current point of view and from Ayurvedic point of view. Next, so we'll conclude today as the time is up. We'll continue in the next session about this. Right. If there are any questions, I'll try to answer, and then. Right. There are no questions, so we'll wind up today. We'll continue in the next session.